Well, good morning, everyone. From Raj Dave from Camp Hill, Pennsylvania. Welcome to Coffee Cases and Controversies, another blockbuster session today. We have an incredible lineup for you to enjoy today. Dr. Jaikirshan Khatri, Dr. Khaldoon Alaswad, and Dr. Amir Kaki. So this is going to be a great fiery session. Without ado, because we have a short time and we have a lot of international folks here, who has joined us today. So let's get going. Dr. Khatri received his interventional cardiology training at Emory University, and he's now the director of complex coronary intervention at Cleveland Clinic. His focus is chronic total occlusions. He has been a frequent speaker at C3 meeting and part of our CTO consortium at C3. In addition to his coronary practice, he also does a lot of vascular work as well as structural interventions, and is an expert at the alternative access. So without further ado, I'd like to invite Dr. Khatri to do the first part of this session. And he's going to talk about today a new CTO wires.
Great, very good. Thank you so much for the invite, Raj. I really appreciate it. Are my slides up on the screen?
Yep, we see it great.
Great. So I'm going to share my experience with the Gaia Next series wires, and I'll show you what's different about the wire and why I think it's really kind of helpful in CTO PCI through some cases. And we'll try to keep this on time. I won't hog too much of the time. So this is kind of a busy slide, but I just want to share with you a couple of things. This is sort of my thought process for how I select guide wires for integrated wire escalation in CTO intervention. So I group it into three groups with low, intermediate, and high penetration force wires. And in the low penetration group, I use Fielder XTA for the most part. And the idea with these wires is you really can't feel anything. It's a soft polymer jacket wire, and it's designed to find microchannels and track soft tissue and just sort of passively find the path. Whether it's subintimal or true lumen, that's sort of irrelevant, but it's not really meant to be something that you're directing actively. You're just letting the wire find its way. The second group of wires is this intermediate group of wires, and this is where the Gaia Next series comes into play. I use Gaia Next 2 and Gaia Next 3 quite a bit. And now these wires are designed to actively track through tissue, whether it be intraplaque or extraplaque. You basically have used the angiogram or some other wire as your tool to direct this wire, and then you're physically driving this wire with tactile feedback and fluoroscopic cues through the lesion. So this is a much more active process. And there's this concept of deflection and rotation. I'll show you that on some of these films. And then the last group is this high penetration wire. And this is basically just to make a hole, to penetrate a cap, and then that's it. There's no other role for this wire. And I use Horner 14 and Stato 20. So those are the three groups of wires that we use a lot. So what is a Gaia Next wire? So there's this structural concept that Asahi has for a lot of their wires, and it's this dual coil composite core construction. And it has different branding depending on which part of the world you're in. In the US, it's called Act 1. And basically what it means is that there's a composite core of dual cores, and then there's a coil within a coil. And what this does is it gives this wire tremendous tactile response and tip shape retention. And this has sort of been a revelation in terms of CTO intervention, in terms of what these wires can do. And they come in different applications: stiff wires, soft wires, jacketed wires, tapered wires, but they all have the same construction. The problem with these wires is that if you dig them into tissue and you rotate them enough, you can actually break them. And this is a wire that we actually broke, and you can see that the coil starts to separate. The problem is that this coil is not visible on fluoroscopy. It's almost invisible. So if you see the tip stop moving when you're rotating the back end of the wire, that's a problem. And that means that this wire is broken, and you have to put in a microcatheter to try to remove the whole wire. If you don't do that, you might leave all of this behind, and that might be hanging out in the aorta. So this is sort of the downside of the old wire construction. And that's where Gaia Next comes in. So Gaia Next has some of the same features that the original Gaia series had: the Act 1 construction, the tapered tip that's pre-shaped. But what they did now is they've changed the outer spring coil, and they've made that coil out of a whole series of smaller wires. And you can see here. So the outer coil is actually a rope of much, much smaller wires that are coiled together to make this spring coil, and they call this X-strand. And what this does is it gives this wire tremendous torque response, tape ship retention, and the ability to not break. It just doesn't break the way that the old wires used to break. So they changed the penetration force. Gaia 1 is now 2 grams. Gaia 2 is now 4 grams. Gaia 3 is now 6 grams. They're slightly more torque responsive than the old series, but the biggest news is that they just don't break. So let's get into some cases so you can understand how we use these wires. So this is a young patient with an LED CTO with a very blunt proximal cap, relatively short segment CTO. The distal cap, unfortunately, is at a bifurcation, and the distal landing zone is a little small. The good news is there wasn't a lot of calcium or tortuosity. So this did require an IVUS guided puncture. As you can see an IVUS catheter in that diagonal branch. So we initially put in a soft polymer jacketed wire, and it very quickly became subintimal. And you can see underneath this subintimal wire, that little stain, that's the actual contrast of the lumen. So we think that basically we've deflected off course somewhere in here. So this wire was passively introduced. We just followed fluoroscopically and quickly realized that it was subintimal. You can leave this wire there or you can take it out. We had too much equipment in here to leave the wire in place. So we took this wire out, but understood that we needed to puncture right here. And this is where I think Gaia is really helpful. So this is a Gaia wire, which is being actively introduced to that area that we deflected. We can feel what the wire is doing. You can feel the wire deflecting, and then as you rotate, it's basically creating a micro dissection at that area that we weren't able to penetrate with the jacketed wire. And you can see it very quickly punctured and entered the true lumen and went down the LAD without a lot of difficulty. So again, you can see it sort of deflecting. That's when you gently rotate the wire, it creates a little micro dissection in the plaque, and then it pops into the lumen and it's free. So this is kind of the ideal case scenario where a Gaia series wire can be helpful to overcome an errant polymer jacketed wire. This is just a completion angiogram of that LAD. This is another case where I think it worked really well. So this is a patient with an LAD CTO where honestly, the only reason that we did this CTO was to have access to this epicardial to fix the RCA CTO. So this one is relatively short, less than 20 millimeters, tapered cap. There's a moderate amount of calcium in here. The distal cap is at a bifurcation. My favorite thing to do here is to take a soft polymer jacketed wire. So that's what we did here. This is a Fielder XTA that we introduced to the cap, and you can see it starting to spiral around this left main, which I don't honestly think is a problem. For me, this is just basically a way to outline the anatomy, where I do want to go, where I don't want to go. And so based on what this wire did, we know exactly what the next wire has to do. So if you study the angiogram more carefully, we think that we deflected off course right here. So we leave the XTA in place and we introduced a Gaia next to, and you can see the Gaia next to is positioned right where we think we deflected off course. Then we start gently rotating that wire again. It can dig through the cap, and you can see how it takes a very, very different course than the Fielder XTA. Rather than spiraling around the left main, it punctures the plaque, and then it is able to enter the true lumen distally. And you can see that on the next set of films, that the Gaia has clearly found the true lumen, and then we were able to complete this left main intervention. Patient came back. A few weeks later, we went down this circumflex through the epicardial and fixed the right coronary CTO. This is a patient who presented with an anterior STEMI, had an emergent LAD PCI, and then during his hospitalization, he was referred for complete revasc. So the plan here was to fix the circumflex CTO as well as the left main on our way out. So this CTO is got a nice tapered cap. The lesion, it's questionable whether it's 20 millimeters or less. You know, it's hard to know in a circumflex, they're so three-dimensional. There's a moderate amount of calcium. The distal cap is unfortunately at a bifurcation. The vessel is kind of small. I didn't think ADR was a great option here. We would probably lose some of these branches. And a retrograde really wasn't very appetizing. The epicardial collateral connections were not ideal. So we wanted to do this antegrade. So when I don't really know the course of the vessel, what I really like to do is take a intermediate tip jacketed wire just to see what it'll do. And whether it pops through or spirals around is kind of irrelevant. What I really want to do is take away some of the ambiguity of the vessel course. So we took a gladius wire, and you can see it very quickly started to spiral around the circumflex. But now I know exactly where I need to go. I know exactly where I don't want to go. And now I can take an intermediate steerable wire. So you can look on the right panel. You can see there's a little bit of contrast here to the left of the wire. And then ultimately, we need to end up to the left of this gladius wire because the lumen appears to be right here. So now we know exactly where to go. We take a steerable wire. In this case, I took a Gaia next to. And again, we introduce this into the plaque, and gently rotate. You can feel the wire digging and dissecting the plaque. And that's what's happening in the left panel here. And once we think we've created a path that's clearly different than the gladius made, we're very happy. And then we just gently keep probing. And all we want to do is end up to the left of the gladius, which is what happens in the center panel. We're to the left of the gladius. And then in the right panel, we inject the right coronary artery. You can see that the Gaia is clearly in, and we just advanced it into the branch. And we've re-entered successfully and completed that case. Just to illustrate to you how incredibly steerable this wire is, I just want to share this kind of interesting case that we did a little while ago. This is a patient with an LAD CTO that had a left-to-left connection from a small diagonal to a second diagonal via an epicardial and then back to the LAD. A little confusing, but what I'm showing you here is this microcatheter that's gone through the diagonal, through an epicardial, and then back down to the LAD retrograde. And then I introduced a Gaia next to antegrade. And just to play around, because we had some time, we just started probing and steering this wire. So we're digging and probing. We can feel, and you can see that the Gaia actually was able to tip right into the retrograde microcatheter. So we ended up making this an antegrade case just by using that retrograde microcatheter as a target. But the wire is that steerable that I could actually steer it into that microcatheter, which I thought was pretty impressive. This is a case of a blunt RCA CTO with no proximal cap at all. For these types of cases, we like to do CT co-registration. And what we intended to do was do E-card. So bring in a wire retrograde, electrify it, and then bring it out in the aorta and snare it. But this is when we first had the Gaia Next series wires, and we thought we would play around with this. So what we did is we introduced a JR4 based on where the CT said the osteo should be, brought a microcatheter retrograde, and then just probe with a Gaia Next 3 just to see what would happen. And you know, this is obviously a little bit of luck here, but you can see with a little bit of probing and deflecting and torquing, not only did the Gaia exit into the aorta, it actually entered the antegrade guide catheter. So it, you know, it took away the need to even snare. So a little bit of luck, but a nice demonstration of just how steerable this wire is. So in conclusion, I would say that these purpose-built intermediate Gaia wires can achieve a high level of lesion crossing when you have unambiguous anatomy. They have really, really ultrafine torque response, and they have a really flexible tip. So you can tell when you hit some very hard plaque because it'll immediately deflect, so you can sort of redirect the wire. That conical tip on the wire lets you re-engage a different path. So just because one path is wrong doesn't mean that you can't make another path. So unlike a jacketed wire, which will always go the same way over and over again, these wires can be redirected into different paths if you're not happy with the first path. And the key with the Gaia Next is that that coil makes it really resistant to tip fracture, which was the big problem with the other wires. So the Gaia Next series success, I think, can really improve this with intravascular imaging, particularly when you're doing a reverse cart that's not working. If you use intravascular imaging to make sure that the both wires are intraplaque, and then use a Gaia Next to complete the connection, I think that's really helpful. I think that polymer jacketed wires, whether they're subintimal or true, can be really helpful to resolve some ambiguity so that you can then direct the Gaia wire. And then you just need to carefully study the angiogram and the fluoroscopy and then pay attention to the tactile feedback to make the best use of this wire. So I went really fast. Hopefully this was helpful. This is my contact information.
Very good. So there is a question from the audience here that are you using Gaia Next as your first go-to wire in a CTO case? So you start with another wire and then go to Gaia wires?
I always use a polymer jacketed wire, and I prefer to use soft wires. XTA, I like to see what the XTA will do. If it goes subintimal, that's fine. But I like to define the anatomy with a soft jacketed wire, then I'll go with the Gaia.
So Dr. Olivecrona, professor of medicine from Lund University in Sweden, and one of the CTO experts in Europe has also joined us. Goran, you know, what is your first wire when you do CTO case? You know, are you starting with the polymer jacketed wires, or you go straight to Gaia series, or what's your favorite method now?
I think that, thank you, Roger. Thank you for inviting me, and great presentation of the Gaia Next. My personal, experience is that I usually use a Fielder XT family type wire to start with. Either a Fielder XTA, sometimes the XTR, just to get a wire and see how far I can go, and then getting a setup for, regardless if this wire does well or not, you have a wire in place that you're going to still need for if you go retrograde, for example, or as was presented now, going ahead with a tight Gaia wire to use that wire as a parallel wire.
Cal, what is your experience?
Yes,
sorry?
so I actually learned a lot from Jai talk, and it's amazing. And I actually have so many questions for Jay. The Gaia Nix now become actually my to-go-to wires for so many functions, including not only anti-grid wire escalation, also I find them very useful when I'm trying to wire retrograde, either make the connection or cross true-to-true retrograde. But I also now kind of exclusively use Gaia Nix 3 for even my ADR. And so I don't use the Confianza Pro 12 or the Stingray wire anymore, or even the Hornet. I use Gaia Nix 3, and I found it's more successful in a stick and drive. But if you allow me, Raj, to ask Jay, because this is a very, very important subject. I want Jay to tell us what he thinks about the learning curves of how to use Gaia, because I remember my first time I used it, and I think I perforated the vessel, and that's gonna set up for my next talk. I have so many questions. And I want to ask Jay the second question, and I'm only going to utter those two questions. Do you sometimes change the shape of the Gaia?
I don't change the shape of the Gaia because the big strength of the Gaia is its rotational power. So when you torque a Gaia, the tip responds very, very precisely to what you've done on the back end. So if you prolong the length of the bend, then the rotation is even bigger.
Yeah.
Your dissection is bigger.
That's true.
What I use the Gaia for is to make a micro dissection. So I can feel the tip of the wire engaging a cap, and then a little bit of rotation creates a micro dissection. If you put a secondary bend on it, then that rotation is a bigger orbit and you get much bigger dissection. So I know that you need that sometimes, but I feel like that kind of defeats the purpose of what this wire is made for.
Yeah. So my first question was, can you comment about the learning curve and how you will advise the new operator who has not used Gaia before? How do you think they should develop these skills?
I think that the best thing to do is to take a soft jacketed wire first. It's either going to pop across or it's going to get subintimal, but it's going to define where to go and where not to go. Then you take a Gaia, which is very, very directable, and it can add tremendously to the safety of using that wire, because now you know exactly where you want to go and where you don't want to go. I think going up front with a Gaia, particularly when you don't understand anatomy, is dangerous.
I think I absolutely agree with you, and I think those kind of the safer cases, I will use the Gaia when I actually want to learn something. I'm going to use it with the guaranteed success or safer cases or easier cases until you develop it, because it's not like any other wire. It's not a spinning wire, and it's like it's completely different. And people kind of need to start building their experience with it slowly. And I like it for instant re-occlusion. You actually go step by step all the way through the stent, even with an angulated stent.
So Dr. Hanif from Asia Pacific CTO Society has joined us, and his question is today that there is this typical technique of drilling, and then penetration, which has been used for many years in Japan and Asia Pacific, with the Miracle, family wires. Mm-hmm. What's the difference between, the Gaia's spinning ability and do you spin them like how you do Miracle wires, or do you it's a more of a pushability than a spinning?
Yeah, so I think that the best way to understand is a wristwatch. So a wristwatch, when you push, it does this, right? So this is what a Gaia wire does when you push. But when you twist this band, it's very strong, right? So that's what a Gaia wire is doing. So the tip is super strong. When you do this, it's so strong. It's meant as a micro dissection tool. It's not meant to drill. So you engage tissue, you'll see it deflect if it's too hard. If it doesn't deflect, that means that you're in some tissue that you can dissect now. And then if you rotate the wire, it'll break that tissue apart. And then you advance a little bit further and you keep doing this step by step. So it's not a drill. It's basically like a little micro dissection tool. But if you hit something very, very hard, it'll immediately do this. It'll bend, and then you can't go there. You have to pull it back and try somewhere different.
Great answer. One more question, and then we'll move forward. Dr. Chandra was up from Midwest. What's the microcatheter of choice with the Gaia wires?
Anything. Just use one.
Yeah, just use one, exactly. And this is what I like. I don't think the Gaia wire works without microcatheter.
Yeah, you just
shouldn't
need
use it. Yeah, you should not use it without a microcatheter.
Goran, do you have a microcatheter of choice? I know in Europe there's more availability now. There's 3 types of Corsairs, regular Corsair, Pro, and then XS. You pick one for yourself, or you have all 3?
We've got all of them, as well as the turnpikes and fine crosses and so on. I think what was said earlier is that you have to use. I've never used a Gaia wire without a microcatheter. So any will do, essentially, whatever your choice.
Now, Jai, I saw that in several cases that you had used an IVUS guidance for entry into a blunt CTO at a bifurcation. Mm-hmm. What size guide are you using? Is it a 7 or 8?
Yeah, I mean, I think that's a great question, because that actually helps me determine what type of microcatheter I'm using. So I like to do a lot of my cases by radial. And so for the IVUS guided side, I'll use a 7 French. And with the 7 French, you can use a low profile microcatheter like a Turnpike LT, Corsair XS, Caravel, Fine Cross, Telemark. Any of these low profile microcatheters will fit through a 7 French guide and a Volcano IVUS or a Boston IVUS. If you are going to use a larger microcatheter like a traditional Corsair or a traditional Turnpike, then you'll need an 8 French. So if you're going radial and you want to stick with 7, you'll have to go with the lower profile microcatheter.
And that's a great answer. And I think just for the audience, we're talking about a 7 French guide from the arm. And we're talking about having the Volcano IVUS catheter and microcatheter both at the same time in the system, to finish the case. Well, that's a fantastic presentation. Lots of great pointers about CTO techniques and the wires. Let's continue with our program. I'd like to now have a privilege to invite Dr. Khaldoon Alaswad, a longtime friend and a great CTO operator who serves as clinical assistant professor at Wayne State University and is director of cardiac catheterization laboratory at Henry Ford Hospital in Detroit. He has been at the forefront of CTO interventions. And today I asked him to present to us some tools to solve the CTO complications, because all of us are going to see this. And I think it's important to keep techniques of how to solve complications during CTO interventions in front of you so that your procedures are safe.
Thanks, Raj, for inviting me. This series has been amazing. Congratulations, and you've done tremendous work educating our community about how to make interventional cardiology better. And thanks for the panelists to be here. So today I'm going to talk about complications. And I did not list the complications, but the most dreaded complication is actually perforation. There are a slew of other complications, which is you treat them normally. If you dissect the donor vessel, you can have to stent it using IVUS guidance, and you put a balloon there. But I'm going to concentrate on how to treat, how to use coils, how to use covered stent, and some of the embolization and what you need to have in your cath lab. So the perforation, as you all know, there are vessel rupture and there is an end hole perforation. An end hole perforation, this is when you wire exit a small side branch, the apical branches of the PDA or the LAD or the diagonal, and you'll see a little bit of flow there. If you see here in panel D, there is a little bit of flow in here in panel D, and you have to pay attention to these things and what to do about this. A lot of times, if you're done with your procedure, you can actually reverse. After you remove all your gear out, you can bedside echo, reverse by not complete reversal. I use 20 to 25 unit of protamine, and wait But sometimes if they continue to bleed, you have to do something. And these are the tools available to you. If you use a thrombin, it's very, very important to occlude the vessel proximal to thrombin and inject through an over-the-wire balloon. And that's the only way to do it. And if the perforation spills into cavity, any cavity, you have to make sure that you cannot use thrombin. If you can close the other end, because the thrombin spilling into cavity going to translate into stroke if it goes in the left system, and it might translate into bigger thrombus if it goes in the right system. So you have to use coil. And this is here a very available material. This is actually piece of the patient's fat himself. We took it with Kelly from in the groin. We stabbed, and you get it, and you see here the microcatheter is filled with saline, and when you put it and you flip it upside down, it's a float up. You can then inject it into that. So again, do not inject these things into cavity. So if you have a cavity spilling, if you have a collaterals that's still connecting to the other end, I would prefer to use coil. So coil, you need to make sure that you have all the coils you use are detachable, not the pushable coil. Do not use pushable coils in the coronary artery. So remember to do perf puff. This is a CTO, final stenting, ready to go home. We deployed the stent, and this is what we found. You have to be facile in delivering covered stent. So these are the new covered stents, and since the Geomed stent was horrible to use, now these came kind of lifesaver, and now these are actually more of a lifesaver. There are pointers how to use them. If you notice here, this is the PK Papyrus. It's a one layer of polyurethane covers over one layer of stent. This is two stents with, in between them, there is a PTFE in a graft master. So goes without saying that you can deliver the PK Papyrus a lot easier. In fact, you can deliver up to 4 millimeter via a 5 French guide catheter. The 4, 5, and 5, you need 6 French guide catheter. What did that change? We used to have this vexing problem. You inflate a balloon in a perforated or ruptured LAD, and you have to obtain another guide access to deliver your you deliver your covered stent. The graft master, you still have to do that most of the time. But now with the PK Papyrus, if you have a 7 French or 8 French guide, you really don't have to. You can actually fit a balloon and a PK Papyrus in, and you can deliver it. So the PK Papyrus, it's very responsive to balloon inflation. The first time I used it, the classical teaching was to take the Geomed and the graft master to take it to very high pressure. When you take it to very high pressure, the edges of that balloon grow so much, you can actually rupture the vessel again. So at the edges, and you have to add, and you have to go back again and cover those. So honestly, once you have a perforation, you have to have an IVUS. You deploy the PK Papyrus, you take a puff. If you still have something flowing around it, I will go with a shorter balloon and now take it, leave the edges alone, and go verify that the edges are good. So I still have both covered stent on the shelves, because sometimes the PK Papyrus, for some reason, cannot, it slips off the balloon so easy. Hence, because it's so deliverable, you need to use a graft master. You cannot, if the PK Papyrus. And sometimes I had one occasion where the PK Papyrus did not stop the bleeding, and the graft master it did, because I'm not sure why, but we probably going to move into having just the PK Papyrus, because we have not needed a graft master for a long time. Now, there are those who do CTO know that the vessels are a lot bigger than 4 and 5 millimeter. Sometimes the adventitial part. So if you did an ADR in a vessel and you deliver in a 5 millimeter PK Papyrus, these dissection planes do not seal that easy. And there are few occasions you might need to use those covered stent, the Viabond covered stent. Those who do peripheral know those really well. And I want you to notice here, 6 French, that meaning 6 French sheath, not a guide. So 6 French sheath is an 8 French guide. So you need to basically have an 8 French guide to deliver those 2.5, 5 millimeter, and those can seal the entire thing more, and you have to dilate. These are self-expanding stents for those who don't use them. There are some of them are actually balloon expandable, but they are difficult to deliver, but sometimes you have to have those on the shelves. So small branch perforation that happens frequently. You wire while you're concentrating on opening this RCA CTO. After we opened it, the patient actually developed an RV infarction picture. We opened this vessel because there was 2 marginal branch lost. I opened this, there is a TIMI 2 flow in it. I said, good, I was opening this one, and we ballooned it. And after that, ballooning it, and this is where we end up. This hematoma, I want you to pay attention to it. It's right over the RV. And this is post-cabbage. We used to think post-cabbage is actually good. They will not develop pericardial effusion or tamponade. We are proven wrong. The localized hematoma is a lot more trouble than actually free-flowing pericardial effusion that you can tap. This can compress the RV, and there is no solution but opening the chest. So you have to act really fast. In this situation, I had like the double jeopardy. I have an RV infarction that I had to open side branch, and then one of those side branches that we struggled so much to open, we end up having a perforation. So I have one side branch. I had no choice but to basically use coils. So these coils, the detachable coils, go over any microcatheter. You have to have those in your lab. You cover it and the coils, and you make sure that there is no perforation. Sometimes you still have a little bit of blood flow. I will pull all the equipment, give protamine 20 or 25, no more, because you can cause stent thrombosis more than that. And you wait your time. You wait in the cath table, repeat the bedside echo. And if you notice here, this is right heart catheterization. This is how I do it if I'm not feeling 100% sure that the patient. Always put right heart catheterization. It's one of the most important early signs of tamponade, even in the ICU when you send the patient. Please do not use pushable coils in the coronary arteries. These are coils you have to be facile at them. The Axiom coils from Medtronic, they are actually originally EV3, but Medtronic acquired them. I have those, and they are become multiple sizes, 4 millimeter to 6 centimeters. So the 6 centimeter is the length of the coil. The 4 millimeter is the loop diameter, and you need to make sure to pick big enough. Now we're going to talk about snares. So these are the snares I keep in my cath lab, and I'll show you one case why I need them. So this is a patient who had an SVG to kind of diagonal. There is a lot of symptoms. The SVG to diagonal was diseased. And we wanted to, after we opened the diagonal, obviously we did kind of star technique instead of open it, but that was competing. So I said, okay, I coiled the SVG that compete with my native circulation after I open it. So we put the coil, we did a final picture. And if you notice here, I injected too strong, the coil went up. And I wanted to see here, this is actually a Christmas tree SVG that it's one trunk, splits into 3, one in the LED, one in the diagonal, one in another diagonal or marginal branch. And the coil actually, instead of going, I was so lucky, better lucky than good, the coil went out, did not go in the aorta, went down again into the other 2 arms of this 3-armed SVG. And now I have a coil going to the LAD and a coil going into the other diagonal. So it was really not a big problem. If you're facile in coiling, in coiling, you need to be facile in actually snaring. So you can do it. So the problem with the gooseneck snares, this is the 2 millimeter gooseneck snare. You keep 2 to 4 millimeter gooseneck snare in your lab. Make sure to follow snared objects throughout the removal process. Make sure you have a deep engagement of your guide catheter when you're removing things from the coronary artery. Then after that, for some reason, I'm always spooked. I aspirate the guide catheter and fluoroscopy the entire guide catheter to make sure I did not forget anything. These are kind of checklists for me, so I don't make another mistake and I inject through the guide and I have forgotten that there is another thing fallen there. Always inspect the gear when you get it out. If not sure, change the guide without a wire. You cannot put a wire to change it if you think there is something fallen in the guide. It's a very, very important. These snares are different. This is the gooseneck snares I keep here. These are the sizes 2 of 4 millimeter. They are 175 and they need 0.18 microcatheter. The micro elite snares, those are the advantage of those. If you have any microcatheter there, they actually go through it. So I use them through the Corsair, the Turnpike, the Fine Cross, whatever. And these are the sizes, the micro elite snares, you need to have them. The problem with the micro elite snares, if you're in a big SVG, they're not easy to capture. But if you're in actually 2 millimeter vessel or 3 millimeter vessel, they are very, very, very good at capturing things. And finally, sometimes there are no really particular tools, snares or anything you can do to treat something though. So this is a patient, this is 3.5 balloon and I'm inflating probably 24 atmospheres, so much calcified RCA, 8 French guide, we pushing so hard, the balloon ruptures and basically the balloon stuck in the calcium. So what we did, we trapped everything and pulled, and if you look here, the balloon is still there and we lost wire access. So what to do? We basically went back. This is actually how the RCA, I had to recross it again, all over again. And then I could not actually expand the calcium anymore. So I used laser 80/80, even with contrast. Went back to kind of dilate it. Now there is a balloon stuck in here. I can't leave that RCA. I have to open it because if you leave a foreign body in a coronary artery, is gonna basically thrombose. So what to do? And you have to stent it to the side if you can't remove it. And this is stuck in the calcium. There is no way we can remove it. And I just imagining that the balloon is just flopping in the RCA. So and I'm just waiting for it to close. So basically, I couldn't expand it. I thought of using CSI in the calcium, which is I should have used first, or road ablation. And here, the CSI, the small micro crown, did not even touch it. It's like it's so much calcium. I actually used the peripheral crown because CSI approval was 1.25 crown and 1.5. So this is the 1.25 peripheral. And that got stuck itself with the calcium, believe it or not. So now what to do? So one of the tools you have to swallow the crown. And this is basically a guidezilla or trap liner trying to swallow the crown. After we cut the shaft, we advance the guide extension. So the guide extension itself might release it. When it did not release it, I trapped everything at the tip here and pulled hard again. And guess what? That actually solved my calcium issue. I was able to cross it so easy. There was a little bit of hematoma here. And actually, I did not need to do covered stent. And this is the final, and we removed it. Of course, he got ischemic in the middle of the case, so I had to put a mechanical circuitry support really fast to save it. And this patient actually went home the next day. So you have to know to do a lot of things if you are doing complex PCI. You have to learn from our peripheral colleagues how to snare, how to do covered stent. From structure colleagues, you have to learn big bore access. Like you really have to be the jack of all trades sometimes to be able to solve this, like this law firm here. If you have any questions, more questions, these are my contact and some of the books available in the market.
So there is one question from the audience, Cal, for you. that there are occasional perforation that occurs with stenting of the bridge. And that perforation is usually in the cavity. Do they need to be sealed with a covered stent?
So it depends how much how much spilling in the cavity. So far, I've been anything spills in the cavity, you just have to make sure it spills only in the cavity, because a lot of times it will be cavity and non-cavity. So that's actually, you have to cover it. But if it's only spills in the cavity, I leave them alone if they are reasonable. I've had a couple of cases where actually it created a fistula, and I had to go back and treat that fistula with a covered stent later. But if it's a spill in the cavity, I'll leave it alone.
Amir, talking about complex interventions, I know that you've seen a lot of these, do you have any tools that you always have it available in your lab, with all the large bore accesses and potential perforations and, foreign body retrieval, cases, that type of stuff?
Yeah, I mean, I think I was very impressed with Cal's not only his skill but his access to some of this equipment. We don't have that micro snare that he has that'll go through a micro catheter. But I did do when you start doing large bore mechanical support devices, the snares actually become important. We've had a couple this year where the impella kinks on itself, and we've called to take them out. And actually, this week, one of the operators had the ASD device during ASD closure embolized, and they tried to get out for a long time, and the solution was actually very simple. It was taking a much larger bore venous sheath, so we were able to snare it, but they had a 16 and a 14. We changed out the 16 for a 24, and that worked. So sometimes we have equipment that's not really dedicated for complication management, but it's important to note that there's a lot of equipment that we could use that we have that could get us out of these troubles. But Cal is always always, very, I guess, I don't know what the term is, inventive, and can come up with a lot of these solutions. Unfortunately, I haven't seen some of these things that he encounters, but it's nice watching his presentations because it gives us a lot of options we could think about it or call him up when these happen.
And absolutely, Amir, to your point, I actually get phone calls from friends. In fact, yesterday I was driving to our fellows' graduation party, and I got a phone calls. I pulled to the side, I reviewed the films, and I got them texted and what to do and all that stuff. I'm not sure if you're lucky to have complications, so you know how to fix them. And I'm not sure it's a good distinction to have to know how to fix complication. That means you caused a lot of it.
There was one more question from the audience about injecting fat and also about the thrombin. That what concentration of thrombin are you using if you do use thrombin? You showed a bottle of 5,000 units bottle, in your first slide. So how much of that material are you actually taking? Are you diluting it?
Absolutely. Excellent question. This is very important point. So we mix them. That's actually how it comes. It is a bovine. It's actually written on the box, not for injection. It's for topical use only. And you just have to convince your nurses, it's okay, trust me on this. So I'll take actually a 1 cc or 3 cc syringe. I don't dilute it. I mix them and I take them in a syringe that does not have heparinized saline in it. And I flush the microcatheter with or the over-the-wire balloon after I inflate it. Before I inflate it, I flush it with a non-heparinized saline, and I take basically the least amount of injection. Basically, you take, even if you have an insulin syringe that has 1 cc in it, and you inject really, really slowly, and you see what happened, and you have to wait. It's kind of similar to if you do alcohol septal ablation like I do, it's similar to that. You have to really be patient and you have to wait for it. So sometimes I inject and I wait a couple of minutes, sometimes 5 minutes, and then you deflate the balloon and you take a picture through the guide, and you cannot do anything with the balloon after that. After you've done that, you deeply engage the guide, you wait for a little bit of time so the balloon, whatever the thrombus in here, would not be stuck in the balloon. And I pull everything with a deep engagement, and I get the guide I prefer to use all new guide without wire, without anything, because there are thrombin and it induces clotting so easy.
Goran, last time when we met at C3 a couple of years ago, you did a presentation at the deep dive session. Tell us a little bit about your European experience of treating the complications. Is this similar to what Cal is doing in his lab?
Thanks, Raj, and great presentation, Cal. It's a great overview of possibility of complications and how to treat them. We use most of the stuff that Cal presented. I've never used thrombin, and I have a huge respect of that. And also like to hear Cal's comments that with these neuro coils that we're using, which your neuroradiologist probably has a whole host of them. I mean, there are many, many different types. Is there any need for using thrombin today, or what's your? I mean, I use with covered stents and the coils, the neuro coils.
Yeah, the good thing about fat and thrombin that is not shown in X-ray. So
I like that.
So if you don't want to leave anything incriminating behind, you can use it. Of course, the thrombin is sometimes what happened, Goran, if you cannot deliver the coil, like let's say you have an epicardial perforation, right?
Yeah.
So, and you cannot actually, you lost access, you cannot deliver the coil back in there, where the perforation, you occlude the entire vessel by thrombin. But I agree with you. Like if you have coils, you really do not need thrombin that much. I'm trying to think, Jay, anything you think like?
Well, I guess the other possibility is that if you are brave enough to go back, if you can do it with thrombin or fat, then you can potentially go back and try again another day. If you're like Cal.
Yeah. It recanalizes, like the thrombin actually, I think recanalizes after you, like any other clot, it will go away.
Yeah, I think that from our vascular experience where we use thrombin for pseudo aneurysm injections and stuff, it's important to recognize what Cal said is to use a very, very small syringe. It's a very slow injection. And you want to remove everything en masse so that you don't have any potential clotting on the catheter or the guide that you're going to leave behind. So that's fantastic. There's a lot of learning there. Let's continue to move forward. We have a little time left, and it's a privilege to have Amir Kaki, a very close friend and collaborator, who's director of Mechanical Circulatory Support Program at St. John's Hospital in Detroit. He's also Associate Director of Interventional Cardiology at St. John and Associate Professor of Medicine at Wayne State University. His key interest is chip interventions. He's really made his name in alternative access for high-risk support cases. And he's going to show us a PCI optimization case today. It's a phenomenal case. So Amir, let you take over.
Okay, thank you. So it's hard enough following Jay doing a state-of-the-art CTO presentation and then having Cal with his cases. So I'll try to do my best to keep everyone engaged. But I was asked to talk about the role of OCT, and I'm going to give you a couple basic background of the OCT and describe one case as time permits. So the role of OCT gives us the answer of how to treat and why do we choose OCT now at our institution if the patient is clinically amenable. The clarity of images really helps a lot. It's tremendous image quality. We simplify the morphology, which really helps us decide the strategy on how to treat these patients. It's very precise when you talk about sizing as it relates to vessel length and diameter. It takes a lot of the guesswork out. And I really think the standard of care in the future will be this so-called precision PCI. If you look at OCT, I think it's best used pre-PCI and post-PCI, assuming the contrast limits permit. They serve different purposes. The pre-OCT PCI helps us understand the morphology of the plaque, the lesion length and diameter to kind of optimize, our decision making. And the post-ECT is really about quality so that your patient can leave the cath lab knowing that we did the best job possible. And it really, we have some good metrics that we're learning. That's, you know, Illumian 4 will really help elucidate whether these strategies, which we think are intuitive to having more durable PCI results, truly pan out. And I'm optimistic and hopeful that that will be the case. This is just a basic, the basics of OCT. It's actually the learning curve for OCT as you start to do more and more cases, actually a lot easier than IVUS, at least in my experience. But here's just a basic, normal vessel. I'm going to talk a little bit about abnormal vessels. So this is a fibrotic lesion when you're looking at this lesion, and you can see it's fibrotic, but all the layers, the intima, the IEL, the media, the adventitia are all still visible if you look at it. If you look at this next image here, those layers have disappeared and they've been overcome. And this is the difference between a lipid lesion versus a fibrotic lesion. And so here's the fibrotic lesion where you can still see our layers, and you can see here where we have loss of the layers, and this is lipidic. And this is important as we're starting to decide, you know, do you need to pre-dilate these patients? Do you not need to? Can you primary stent? Here's calcium, which is really easy to appreciate it. You can see it around, you know, between 6 and 9 o'clock. Calcium is very easy. And we can also identify a lot of more just beyond the fact that we have calcium present, but where is it present? Is it superficial? Is it intimal? Is it deep? And those are important because they help also craft our decision. When we're looking at thrombus, I actually had a STEMI yesterday and we did OCT. What I've found is that we'll do thrombectomy now on patients who have thrombus like this. This is red thrombus, and this is thrombus as acute, which will completely resolve with the mechanical thrombectomy or vacuum thrombectomy. By the same token, if you see thrombus like this intraluminal, this is a delayed presentation in acute infarct, and you could do as much thrombectomy as you want. Oftentimes, these will not resolve. So, you know, we could learn a lot by doing the pre-OCT. If you look at the types of calcium, we talked briefly about this, but calcium can be classified as deep or superficial or nodular. And you can see the deep calcium is here, close to the adventitia. And here's intimal calcium. And you can see this is nodular calcium where it starts to invade the lumen. And I'm very surprised after you start to do OCT, how much of this we actually have missed when we're doing angiography and IVUS. There is some differences between nodular and eruptive nodular calcium. So this is more on the left. You can see this is a more stable, what we describe as nodular calcium, and you can see the histology side by side. But here's also nodular calcium where it has a tick for that ruptured, and this is how it would look in the setting of AMI. So not all nodular calcium is the same. You can still have nodular calcium in the setting of AMI. Historically, we would think that calcified lesions are more stable, but as we're doing more and more imaging, we're starting to challenge, you know, some of the things that we used to believe to be true. This is actually a really nice scoring algorithm that we're using now to dictate, you know, how we approach calcified lesions. This is Fujino, and he gives, him and his group give 1 point for any one of these characteristics. If the angle of calcium is greater than 180 degrees, you get 2 points. The thickness is greater than 0.5 millimeter, you get a point. The length longer than 5 millimeters is a point. And you could score it, obviously 4 being the highest. This is you know, it looks kind of complicated, but it's actually super easy. This is a algorithm that was by Dr. Schlafmitz and his group that published on their approach to calcium identified by OCT. If you identify calcium on OCT and it's deep, the recommendation is to use a scoring or cutting balloon. Oftentimes that's the suffice. And then you could do a stent and a post OCT, but this has been adequate in preparing these vessels. There is some data to start coming out recently that actually lithotripsy is effective in deep calcium as well as superficial calcium. If we have superficial calcium, the question is it balloon crossable? If it is, and it's circumferential and it meets the criteria that we talked about in the Fujino 4, you could use IVL if you have it in your cath lab, and then confirm that the lesion has been adequately prepped, and then you could move on to stenting. In patients where you can't cross with a balloon, you're really left with atherectomy. Here, the recommendation is rotation or orbital. In my practice, we've also used laser in some of these cases if we can't get the orbital or rotational wire down. We always try to recommend after you prep these vessels. You know, Cal showed a case where he had they had underexpanded stent due to heavy calcium. And the way to avoid that really is after you prep the vessel to make sure that you image or have complete dilatation of a non-compliant balloon, a size 1-to-1 before you put your stent in, so that you could avoid that notion of stent regret. So this is an interesting algorithm that I'll show you how we apply it in this particular case. So this is one of my patients who had an abnormal stress test, and just by looking at this, I said, there's really nothing to do here. I thought that I was underwhelmed. And so you could see there was a lesion, and we told the fellows, well, we had a positive stress test symptoms. Well, why don't we image it and see if there's something there? And this is what we learned from the imaging. You could see that this is a very heavily calcified lesion. And as we start to get here, you can start to see, I'll try to slow it down if I could use this thing, where there was actually a very tight lesion that was heavily calcified, and there was a nodular calcium. So I'll run it one more time so you could see it. And I was really surprised because starting to realize how much we miss angiographically when we're not doing IVUS. And here's where the lesion was. I can't stop it. Anyways, we scored our lesion at the tightest area. It had an arc of calcium of 270 degrees, a thickness of 0.9 millimeters, and a lesion length of 6.2. So it meets criteria. We got 2 here, +1, +1. We had a Fujino calcium score of 4. So we did orbital atherectomy. And what I want to show you on this is, look what happens. You could see what happens after orbital atherectomy. Interestingly enough, if you go right here, you can see where the effects of the ablation of orbital atherectomy is really interesting. That I used to think, oh, there it is. I used to think that the atherectomy just changed the compliance of the vessel and really didn't give us any luminal gain. It really prepared our balloons. But as you start to do more imaging, you see that you do actually get some luminal gain with the ablative atherectomy effects. And you can see it there. I'm having a hard time pausing it. Okay, but let me see if I could pause it, because it's worthwhile showing you what how it looks after we do atherectomy. And you come around like close to 40 here. It's not working, sorry. So moving on, this is after the stent. We did an OCT, and we have metrics, particularly looking at minimal stent area and expansion of the stent to determine a good quality result. And you can see here, we got a stent expansion of 85%. Our target usually is to get between 90 and 100. We were able still to achieve a minimal stent area of 4.5, which was adequate. So we felt that this was good enough to leave alone. So OCT really kind of drove our decision-making as it relates to how we approach this lesion, our stent length and size, and our time to treat. And here's the final result. You can see it looks good. And in conclusion, I think intravascular imaging, if OCT is not permissive based on the clinical, it's always actionable, in my opinion. It assures optimal decision making as we're starting to do PCI. It improves the quality and the durability of our PCI. And I'm of a strong opinion, and this may be a bold statement, that intravascular imaging should be the standard of care. And I think in time will be the standard of care for all PCI, given what we're learning and trying to achieve our best outcomes for our patients and more durable results. So with that, thank you. And if we have any fellows listening, congratulations to you guys, and wish you all the best as you embark on your careers. Thank you for having me, and I hope that was useful.
Thanks, Amir, for a wonderful presentation on PCI optimization. We have one question from Dr. Nakano in Japan about use of OCT and deciding the size of a atherectomy device. And any of you can chime in if you like. In Japan, it's common to decide on the size of the atherectomy device based on the OCT luminal diameter and the thickness of the calcium, and then whether they upgrade the device. So what's your algorithm for OCT based calcium atherectomy?
Yeah, I'd be interested to hear from Cal, Jay, and Goran if they're ROTA users. I have to be very honest with you. I'm a predominantly orbital atherectomy user. And, obviously there's one device, and there's, 2 options. You could spin at low speed, and if you want a bigger orbit, high speed. I'll be very honest with you guys. Probably over maybe 250 orbital cases, I would tell you 1 out of every 100, I maybe have to go to high speed. I think what, the dark secret of atherectomy that we don't talk about, at least in my experience, is when you do have serious complications with atherectomy, those are often catastrophic and are associated with very high mortality. So in my practice, I use orbital as my default. I use low speed. I rarely go to high speed. And now that we have IVL in our lab, I have a much lower threshold. If orbital atherectomy does not do what I need it to do, I think it's a safe, viable option to use IVL in those cases. So that's kind of my algorithm personally.
Amazing talk, Amir. I really learned a lot. Honestly, I don't have the OCT in my lab, and it made me more eager to get the lab, get the OCT, and come to you and learn from you. And tremendous experience in this. And I'm always amazed when I listen to you. Humble but very knowledgeable at the same time. I think the size of the vessel as related to atherectomy, so the rotational atherectomy, I use it for plaque modification. And honestly, the biggest burr I use 175 sometimes just because I'm ablating in the left main. I am like Amir, I tend to use more CSI in a bigger vessel, smaller vessel, rotational atherectomy, and I think angiography is good enough. And even the CSI, I use it for plaque modification. However, there are some situations where the vessel is 5.0 with a underexpanded stent or concentric calcium or whatever, and I had to go to bigger crown, and I did go to 1.5 and 1.25 peripheral crown, which is a solid phase, like it can look bigger a little bit. And one time I used actually the 1.5 and it worked fine. And we published actually our experience with that, but I'm not sure that imaging helps you the size of the guy helps you what to do, but not the size. I'd like to learn from our Japanese colleagues about that.
So maybe I can address this for our algorithm at in Camp Hill. So we predominantly use OCT for our imaging here. And there are a few things to consider when you do an OCT in a calcified lesion. One is the wire bias, and that really is extremely helpful in determining the size of the burr. Because if you have wire bias towards a normal, or less calcified, side of the artery, then you don't want to use a very large burr because then you increase the potential risk of perforation. Now we do use combination of rota as well as orbital atherectomy in our lab. I'll give you a perfect example of orbital atherectomy where we would do a proximal LED lesion, which looks like a 2 millimeter lumen, but when you do an IVUS or an OCT, there's still a lot of lumen in there. And if you use a 1.5 or a 1.25 rotablator burr, it's very undersized. So, those cases require a much, much larger device or an orbital atherectomy device. The third thing, that we do, and this is something that I learned from my, Japanese friends. In Japan has a very high incidence of dialysis patients. So they have a significantly higher rate of calcification in the coronaries, and they typically will start with a smaller device, then we'll do an OCT run, and then measure the thickness of the calcium. So I've seen many cases in Japan where after a first rotablator burr run, you still have 600 millimeter thickness of the calcium in all these dialysis patients, and we invariably upsize the burr. Obviously, we have to be careful about the size of the artery. And try to thin it out before you expand the stent. Otherwise, those stents remain unexpanded, especially with the second generation drug-eluting stents, which are not as strong as old stents. Like Crown Flex, when I was in fellowship, was very, very strong. Stainless steel stent. That's almost 22 years ago now. But those stents could really hold a calcified vessel really well. But with the current generation, especially thin strut stents, you have some compression from this heavy calcification. So those are, some of the things to consider, when you do an OCT and calcification. Jay, do you, in Cleveland Clinic, do you use a lot of OCT?
We use a lot of OCT, a lot of IVUS, and now we're getting into HD IVUS as well. particularly because we have a lot of CTO patients that were subintimal, so OCT is hard to use in that situation. One of the things I'd like to add that we do a lot is we do a lot of 1.5 rotaburr and then go in with a 1-to-1 NC balloon, and we do a rotational angiogram to see if there's any residual waste in the balloon. And we use that to determine whether or not we need an adjunct like a lithoplasty balloon or not. And I find that to be very helpful. So I don't really use the imaging per se to decide what type of atherectomy, but I do use the imaging to select the 1-to-1 NC balloon. And then I do a rotational angio to understand whether the balloon is truly expanding the lesion or not.
So can I ask the panelists, just for the audience sake, what percentage of your PCIs in your institution you think are image guided? I'll start with ours. The BMC squared, just a report just came out. The sites are unidentified except your own site. We were ranked third in Michigan out of 29 cath labs, and we were at 67% of our PCIs are image guided. So what do you guys, what's yours, and should we be higher? Should we be lower?
We're well into the 90% range now.
90, okay, great. Goran, how about in Europe?
I think in my cath lab, we have both OCT and IVUS and near IVUS. And I think that we used maybe 20-25% of the time. It depends. I mean, we use it for IVUS, for example, in all CTOs. And if you look upon the complex procedures that we do, and we do a pretty fair amount of complex procedures, it's much, much, much higher there. While, you know, we do 800, 700 STEMI patients, and we don't do it that much there if it's you know, pretty straightforward looking arteries. So I guess it also depends on what kind of patients are you seeing. If you're seeing complex patients, you definitely need to do a lot of diagnostics with image guided.
In our lab, we are probably about 30%, you know, and partly is a function of, you know, the volume and the time. I think it's probably a poor excuse, but you know how it goes, you know, during the day. I do have a last question for Jay. I know we're up with the time. You know, he mentioned something about HD IVUS, and I wanted to ask him, you know, that what HD IVUS does he use, and has he switched over completely to HD IVUS? Because I don't know that Volcano has an HD IVUS. You know, I'm just using the standard catheters.
Mm-hmm. Yeah, the vast majority of our cases are done with the Volcano IVUS, and we've recently been toying with HD IVUS. We have the Boston system in our lab, and I found it to be tremendously helpful. I mean, it's not quite an OCT quality, but like I said, we're often subintimal in a dissection plane in a CTO, or we have a dialysis patient or a near dialysis patient, and so it's a very, very nice second best imaging option, and it gives you the same longitudinal information you get with OCT. So we found it very, very helpful.
Yeah, Cal, what do you do? How are you guys doing, Cal, as it relates to imaging at Henry Ford? You guys do a lot of complex cases.
So we are actually #1 in the state of Michigan. We are at 78.7 or not, I mean, 87.7. So, or now 80%. So of the cases done with IVUS. It's a kind of, we are closed lab, so 11 operators, and we all kind of work in the same wavelength, and we have we find IVUS in the kind of cases we similar, like Goran said, if you see complex cases, you really cannot do those cases without an IVUS.
Well, this is a phenomenal session. Great presentations by three great operators. Thank you, everyone, including Dr. Olivecrona, who took time out of his busy schedule from Sweden today. Thanks everyone from Asia Pacific who is on the show today. I know it's very late over there, and I want to keep you guys. Several people here from Indonesia today. I think it's even later. It's almost midnight there. So thank you very much, and thanks everyone for joining. Have a wonderful rest of the weekend, and have a great day. With that, I will close the show for today. The next show will be on July 10th. We look forward to having many of you join us again. I love to hear your comments, your questions, your suggestions about what you like to hear. We have a phenomenal show in store for you for July. It's going to be on a different type of topics, but it's going to be a great clinical learning. So look forward to seeing you. Thanks again, everybody.
Take care, guys.
Thanks, everybody. Enjoy
See
your
you
weekend.
later, guys.
Bye.
Bye.
I gotta run.